Well, good afternoon. I'm Chad, Associate Director for the Center for Professional Advocacy, APMA. You all know Dr. Christina, our CEO and Executive Director. We're going to talk about the state of podiatry, talking about the legislative and regulatory initiatives that affect our practice, your practice. We're going to first do a little brief history of health system reform, and Dr. Christina is going to talk about the era of value-based payments and an overview of the new merit-based incentive payment system, which is MIPS, which is the quality payment program that was brought forward by MACRA that was passed a couple years ago. And then we'll talk about current legislative and regulatory initiatives. Everyone should have received two handouts. One's an overview of our current legislative initiatives, and the other one is kind of our current topics in health policy and practice. If you didn't get those, let us know. And so, we're going to go back to the future for a second. I think learning about history is important. It's important because, one, it helps us to know where we've been and where we're going, and some lessons we can learn. And for one, the lessons we can learn from health system reform is there's been a lot of changes, a lot of innovation, but through time, we've succeeded. Podiatry is still here. It's stronger than ever, and it's growing. And in part because we met those needs. Especially the foot and ankle care is needed, and you provide that care, and podiatry has grown and adapted to meet those care. So any changes in health system reform and payment reform hasn't predicted that doom and gloom that many have seen. So we're going to go back a little bit in time. Some of the established podiatrists here can correct me if anything I've said that's wrong. We had Dr. Tillo and Dr. Davis and Dr. Christina. They were there. So we go way back to the 1860s. They weren't there exactly, but 1860s to Dr. Issachar Zachari. He was the podiatrist, the late great President Abraham Lincoln, and he was favored by President Lincoln. He's to his foot care, but he kind of fell out of favor because he submitted a bill to the American government because he wanted them payment back for treating Union soldiers. I say this to say in 150 years we've been fighting the federal government for reimbursement, but we're still here. So we're going to fast forward a little bit to the 1960s, a little bit more modern time. 1965 brought Medicare and Medicaid, and then 1967 podiatrists were added to the definition of physician in Medicare. Real quick, Medicare 101. Medicare is a system for 65 and older, and some other individuals. There's 4 parts to Medicare. Part A is for hospitals, Part B is physician services, and then Part C and D, which is added later, and we'll get to, talks about Part C is managed care, and then Part D is prescription drugs. Medicaid 101 is a joint partnership between the states and federal government, and there are certain mandatory services that the states have to provide, and certain optional services. And as many of you know, services by podiatrists are an optional service. Something we're working on for a while now to change is through our HELP Act, is to make podiatrists defined as physicians in Medicaid, so it's no longer an optional but required service. Fast forward a little bit more, the 70s and the 80s brought us the rise in managed care. We saw HMOs passed in 1973. This was introduced by the Nixon administration in part to fight against congressional Democrats who wanted universal health care. And then that's the HMO Act, 73, loosened the rules, so HMOs could be created. Then we saw in the late 70s and early 80s 2 other acts that opened the door to managed care in Medicare and Medicaid. So ERISA began in 1974. It's a very massive bill, and you'll hear a lot about in your careers. But for our purposes, ERISA brought forward kind of more self-insured plans by employers, which use third-party administrators. And third-party administrators do the claims management and financial management for these health benefits as large employers. One of the things that many people saw, the problems with third-party administrators, and probably still today, is their claims management. Maybe they downcode payments, maybe they don't appropriately allow for reimbursement for podiatrists. And so when they first came about, and a little bit today, there's been a lot of issues with podiatrists and other providers and TPAs. As you can imagine, the role of TPAs is to, while administer the benefits for the self-insured plans, but also to make sure those plans don't spend too much money and still do anything they can to not spend money. But through this time, we saw the rise of HMOs, which is that gatekeeper system, the ERISA and the self-insured plans. Podiatric medicine grew even more. We saw CPME residency programs, came more rise in specialty residencies. Education and training came a little bit more standardized. And this was necessary to meet the needs of the foot and ankle care that your patients need. And so even though HMOs, TPAs, Medicare and Medicaid, the growth of healthcare was there, podiatrists were able to adapt and grow the profession to make sure we were able to provide the care. Jumping forward to the 90s and 2000s, we have early 90s, we have the system that I think Dr. Tillow mentioned, the resource value-based payment system in Medicare, which was kind of a big change in how we reimburse physicians. Also at that time, we kind of this Medicare physician fee schedule that was kind of set up. And then APMA was there to advocate to make sure that podiatrists were included in that Medicare physician fee schedule. And so they got reimbursed. So you all got reimbursed the same as MDs and DOs. The 90s also brought about HIPAA, which we talked about earlier. And then the Balanced Budget Act in 1997, which created SCHIP, which is the State Children's Health Insurance Program. Medicare Plus Choice, which is Medicare Part C, which is the Medicaid managed care, and created the Sustainable Growth Rate, which was later repealed in 2015. The SGR was there as a kind of cost containment program for Medicare. Moving along a little faster, we have in 2000 more reforms. The Medicare prescription drug plan was created, which is Part D, and then Part C also, which is the Medicare Advantage plan. Medicare Plus Choice was named to Medicare Advantage. There's really been a rise in Medicare Advantage plans. I don't know if you see it in your practice. We get a lot of calls to APMA about this. And that makes sense. In 2008, about 9% of Medicare beneficiaries were in Medicare Advantage. Today, 31% of Medicare beneficiaries get their coverage through Medicare Advantage plans. That's about 17 million people, and that's only going to grow more. There's certainly concerns we see with Medicare Advantage, the way they have to cover the same benefits as original Medicare. They have different coding and different payment they can use. And again, they also want to save their money, and they're trying to do that in a way of, I can't say screw over providers, but maybe that's what they're doing. And then later in 2000, we saw kind of this turn to value-based payments. In 2006 was introduction of the act that brought forward PQRS, or PQRI, which later then turned to PQRS, which is the Physician Quality Reporting System. But again, even with all these changes, podiatry is still even growing more to meet the needs of your patients. We got further recognition in the public and private payer system. I mentioned earlier, receiving reimbursement under a physician fee schedule. Residency programs came mandatory, education came standardized. We saw the creation of APMA's Vision 2015 program. And then with that, we saw different scope of, this map here is the changes in scope of practice laws to include ankle and lower extremities, which kind of grew even more so in the early 90s and 2000s. And we saw the formation of the Taste of Podiatry campaign to demonstrate to patients that podiatrists are physicians, surgeons, and specialists to show the wealth and the breadth of your training. So 2009 today brings us the era of value-based payments. We have the American Recovery and Reinvestment Act of 2009 and the HITECH Act brought forward the Meaningful Use in EHR program. The Affordable Care Act brought forward ACOs, I think the value-based payment modifier, and then the Center for Medicare and Medicaid Innovation was created, and that was there, and that still is around to kind of look for innovation in reimbursement and payment. And then we have in 2015 the Medicare Access Chip Reauthorization Act, which was passed in 2015. The proposed rule came out in April, and the final rule came out Friday. And that created the Quality Payment Program that which creates MIPS and APMs. And there, I'm going to take it over to Dr. Christina.
Thanks, Chad. Just a little background. So as you got this history, part of the history was important to realize that there have been a lot of different systems that have come through. I graduated from the Pennsylvania College of Podiatric Medicine, now Temple, in 1983, did 2 years of surgical residency. So I entered private practice in 1985. At that time, you talk about timing being everything. Before that period of time was kind of a golden era for podiatry. The reimbursements were very generous. They were based on what's called usual and customary. There was no reduction in multiple surgeries. So if you had a bunion and 4 hammer toes, you got paid full fee on each one of those, and those were what were called UCR, usual and customary payments. As Chad said, the RBRVS system, I believe, came out right in that same mid to late 80s time period, and it kind of changed everything. And I remember actually being at a meeting in CMS in Baltimore when they were considering this RBRVS system, and the concern was that Medicare at the time was probably one of your worst payers if you looked at your payer system, and your private insurers paid very well. And we said the RBRVS system is basically set up on a certain pool of money. That's how it works. That's how much money the federal government has in the Medicare system to pay for the services that are provided. So they set up an RBRVS system. When that gets applied to private insurance, it's a whole different system. They're not held to the same pool of money type of thing, yet they took that RBRVS system and utilized it to reduce fees to the point where, for a lot of people now, Medicare is one of the best payers compared to some of the private pays. Or you're looking, if you can get a contract 120 or 140% of Medicare, you feel like you're doing really well. So you can see that how things change over time. You mentioned the HMOs. At the time when the HMOs came out, everybody said, that's going to be the death of medicine, of podiatry, those types of things. We survived the HMOs. Then a lot of capitated payment programs came out. And those were controlled by the primary cares that would get a certain amount of money to pay for care for their patients, and they'd get paid per person, a certain cap per monthly fee they get, and then they'd lose money from that pool if they had to refer them out for specialty care. That was going to be the demise of care for demise of the profession as well. It didn't happen, because what happens, as you know, we're the best ones at providing that foot and ankle care. The patients get impatient when they don't get healed, and so there was an uprise of that, and you saw all that go away. Then the third-party administrators took over, and that was a whole battle that went through. The point is that there's always going to be changes. We're always going to be here to survive those changes. What we try to do is equip our members with the best way that they can deal with these changes as they come forward. I just started APMA in 2005 when this whole quality measures and value-based system started to come about. And fortunately, we were able to educate our members about how to deal with these systems. So PQRI, which became PQRS, and the e-prescribing programs, those initially they were not penalty programs. You actually could get a bonus for doing those. And for the first few years, if you participated, it wasn't that difficult, and you could get a bonus payment that would pay you your dues to be a member of APMA and then some. So these programs morph and change. What we have to do is be able to provide you with the information to deal with them. So now we're dealing with the merit-based incentive payment, the MIPS program, which is part of MACRA. As Chad said, MACRA was the law. And then within that law that was passed, they talked about these two programs, the merit-based incentive payment system and the alternative payment model payment systems. And so what happens is CMS then publishes, they're the regulatory body. So Congress passes a law, CMS is a regulatory body that we have to deal with. They put together the whole program. They put out a proposed rule. I think that proposed rule that came out was 962 pages, something in that range. So we have to sift through that. There's an open comment period. We always make comments. We say what's wrong with it, what we'd like to see changed, those types of things, as do every other medical association and a lot of others that send this. After they look at all the proposed comments, they finally come out with a final rule. As Chad said, they just came out with the final rule. So now you've got from the other day until the first of the year to be prepared to deal with what was outlined in that final rule. So we go through the process of digesting that, putting it into understandable information so you can understand it. So right now, in 2016, if you're in practice, what you're working under is the Physician Quality Reporting System. which is linked to the value modifier system, and then the use of electronic health records is called meaningful use. So those are 3 separate programs that actually have penalties and a little bit of incentive built into a couple of them as well that impact you in 2016. What MIPS is going to do is they're going to take components of all 3 of those and fuse them into one program called this merit-based incentive payment system. There's also the alternative payment model. We're not going to talk a lot about that. As it was originally proposed, it was going to be very difficult for any physician providers to, and even ACOs and things, to qualify as an alternative payment model. They did supposedly make some changes. I personally haven't seen what they were. I don't know how that impacts us. My bet is that most providers, at least for 2017, will be involved with the MIPS system. Okay, so MIPS starts in 2017. So there are some exclusions. This is one of the changes from the proposed rule to the final rule. So you can be excluded if you see less than 100 Part B Medicare beneficiaries over the course of the entire year, or you bill less than $30,000. The original rule, I believe, had an and in it, so you had to meet both qualifications, and it was $10,000 the threshold. So for somebody who practices part-time, this is probably going to be more for either somebody that's more of a senior person that just does a little bit of part-time work where they don't see as many Medicare beneficiaries, or if you're in private practice and you don't see Medicare patients or see very few, you could be excluded. If you're newly Medicare enrolled eligible clinicians, so that could impact a lot of you. If you're finishing your residency, just starting into practice. If you're in a qualifying alternative payment model, as I said, that's going to be very few, and there's also some that you can be what they call a partially qualified. So these are the 4 components that there are to MIPS that starts in 2017. And it's going to move forward through the years, and there'll be changes in what happens with each of these components. But they're looking at performance, sending in performance data, feedback, and those types of things. Here are the categories that they're going to be looking at. So they're going to be looking at quality care. They're also going to be looking at advancing care information. They're going to look at clinical practice improvement, and then they're going to look at cost. Now, the cost segment actually was another change in the final rule. In 2017, they're not going to look at cost. So you're only going to be looking at the 3 things, the quality, the advancing care initiative, and the clinical practice improvement activities. The first 2 combined kind of the PQRS and the meaningful use. The third is new, the clinical quality improvement activities. Those are new, and they've listed what those can be. And we actually are now sending some feedback to CMS as to what clinical practice improvement activities may actually be applicable to the practice of podiatry. So that just kind of shows you a graphic breakdown of all the components of MIPS as they were proposed, but as we now know, the cost component is not going to be a factor for 2017. And the cost factor is really the one that's of concern to us because of the way that it's written. The things that they look at when they consider cost, a lot of them aren't applicable to podiatry. A lot of it has to do with readmissions to the hospital and care within the hospital setting and those types of things that they can't get a true cost read on certain specialty providers, and podiatry would fall into that group. So we had concerns with cost. We commented on that. Obviously, they're delaying it for a year, hopefully to make some improvements. One of our recommendations would be it makes more sense from a cost perspective to see how you're functioning by comparison to your peers that do the similar type of work. So that's one of the things we'd like to see them implement into this whole cost equation rather than looking at particular quality parameters and how they impact cost. So there's different ways that you're going to be able to submit this MIPS data. And one of the things that they're going to do in 2017 is they're giving you options on how much you engage in using MIPS, and they're making it fairly simple. So to if you do the bare minimum, which is to submit some data, then they're going to let you avoid the penalty just by submitting some data. If you submit a more robust bunch of data but don't necessarily meet all of the MIPS criteria, you might get a small incentive. And if you go full on, try to do everything you're supposed to do with MIPS, then you have the potential to actually get a little bit bigger actual incentive payment. But avoiding the penalty next year is going to be very simple. It's just going to be the matter of submitting some data. And one of the ways that you can submit this data is through what's called a qualified clinical data registry. So as I know Dan mentioned and Diane mentioned as well, at APMA we're developing a registry that our members can submit to. Our goal, phase one of that project that's going on right now, which is almost 40% complete, is to submit to CMS to be a qualified clinical data registry for 2017. So what that'll mean as an APMA member, you're going to be able to submit data to the registry. The registry will report to CMS to meet those MIPS requirements that you need to meet. Registries typically charge anywhere from $300 to $500 per provider for that service. This will be an APMA member benefit. So right from just the get-go, you'll see that there's a benefit to reporting data to the registry to being an APMA member. And I'm going to talk a lot more about the registry tomorrow morning, go into more details what the registry is, how registry works, those types of things. But our goal is to be that, as you can see, you can do it through attestation, you can do it through a qualified registry, which is a little different than a qualified clinical data registry, or you can do it directly from your EHR vendor. We're going to be offering that QCDR option for our members in 2017 to satisfy MIPS. The payment adjustments, the way the payment adjustments are set up, you can see they're gradual. They're going to be going anywhere from -4 to +4 initially, and then they will gradually increase. What they'll do is they'll take all the components. They'll take the quality, the resource use, the clinical practice improvement activities, the advancing care information. Each of those is set up to give you a different score on each section. They put that all together, they come up with your MIPS composite performance score, and then they have a baseline score that they'll compare to, and depending on where you are in relation to that baseline score, you're either going to get a negative or a positive payment adjustment. If you happen to hit right on the button on the line, you get nothing, but that's going to be rare. And there's going to be winners and losers. So what they'll give out in the plus side of that is based on how much they take away from those that are on the negative side. So it's going to be important because this is going to be graduated. It's not as much all or none as like a meaningful use. If you don't hit all 10 objectives of meaningful use, you don't get it. You can hit parts of MIPS so that your MIPS composite score may not be the highest it could be, but it's better than somebody that does nothing, and that's going to throw you into either less of a negative adjustment or even possibly a positive adjustment. So again, we will put out the resources to explain how you can meet the requirements that are required under each of the 4 components of MIPS. This is what I was talking about, the pick your pace. That's where they're now saying that at least for 2017, you can just, if you don't participate at all, but you submit some data, you're going to get the 0, or do some, you're going to get the negative if you do nothing. If you don't, just submit a little, you're going to get some, you'll at least be at negative, then you do some, you get a little positive and even more positive. So you're going to have options on how you can do it. Part of the concern when all of this came out is if you look at the performance of podiatry relative to the physician quality reporting system, and the data is that we have not performed well. So this is the highlighted column. Those are those that are subject to the payment adjustments for each year. And you can see it was 49%, almost half in 2015, jumped up to 70%. So podiatry has not been participating in these programs. And PQRS being a part merged into MIPS, the prediction would be that podiatry is going to do very poorly and they're going to be subject to payment penalties. Also, larger practices are going to be favored in the MIPS program, they think, as opposed to smaller practices, because larger practices generally have some sort of manager that can help you deal with all the components of MIPS, as opposed to a small or a solo group practice. You've got to do all that on your own, and that becomes very burdensome. from the standpoint of having to meet all these requirements, know what they are, know how to do the submission and those types of things. We'll have the resources to help you do it. It still doesn't take away the burden, and that's one of the things we talked about in our comments on the proposed rule, is the burden that this places on the small and solo group practices. So we will have information. It's up on the website. Being prepared is very important. One of the reasons we were so successful with ICD-10 is that we pushed out all the information and just hammered it home. This is what you're going to need to do, so that when October 1 came, when ICD-10 went into effect a year ago, we were prepared for it. And our members did very well, and it wasn't the end of the world. We think the same thing can be done with MIPS. We've got a macro task force that's working on this. We have resources that are available on our website. We do webinars. If you haven't gone to the APMA website, go to the website, click on podiatric education or education and resources. Underneath that, you'll see webinars. Click on that, you'll see archive webinars. They're recorded. If you don't have time to actually participate in it live, you can sit down and listen to the recording. You can look at the PDF of the slides that were presented. So there's a lot of resources available. You don't have to get hit with these penalties if you just do a little bit of homework and use the resources that we're trying to make available for you so that you can do well with these programs. I'm going to turn it back over to Chad and let him go over some of our legislative priorities now, where we're trying to actually affect legislation to make changes. He talked about how it's interesting with Medicare. We got into Medicare back when Johnson was the president, and how that happened highlights the importance of relationships that you may develop and letting us know about those relationships. It turns out there's a podiatrist in the Rockville area in Maryland named Charlie Turchin. He was the podiatrist to Lady Bird Johnson. And when he heard that we weren't included in Medicaid, he started to get her ear, who in turn got President Johnson's ear, and the whole process started to move forward, and eventually we were able to get included in that legislation in Medicare. So it's important, if you have contacts, if you have patients, if you have personal relationships with members of Congress, those types of things, let us know. We can help leverage those. We can give you information about the priorities so that you can become an ambassador for the profession and really educate them on the needs that we have legislatively. And this is very important. They listen to constituents. That's one of the most important things you'll learn as you go through the process if you're involved with either your state legislature or on the federal level. The people that they listen to are their constituents. So when you write or call or visit your congressional member, they take note of that, as opposed to we can go in as a national organization and present the priorities, but the real important thing is when one of their members in their district comes in and speaks to them. So I'll let Chad give you a highlight of what we're working on now.
We'll talk about our priorities. This is kind of our general priorities: parity with MDDOs, attain professional recognition as physicians, and maximize reimbursements for podiatrists. As we go through this, you'll see this is kind of what we go back to and what we kind of lead towards. So our federal legislative priorities, Dr. Davis mentioned earlier, our VA Provider Equity Act. This bill will allow for DPMs to be on the physician and dentist pay band in the VA, and as Dan mentioned, it would help with a lot of retention and recruitment at the VA. And so currently, the bill was introduced in the House by the primary sponsor was Congressman Brad Wenstrup. He was a podiatrist, I think the first and current only podiatrist in Congress from the Ohio area. And the bill was put together part of a larger package and passed the House last spring, I believe. And then the Senate was introduced by Senator John Tester, who is from Montana. He's on the VA committee in the Senate. In the Senate, they have their own large omnibus VA package. Our provision was not included in there, but that large bill passed out of the Senate committee and may be considered, likely considered by the full Senate after the election. And this was called lame duck period. If that bill is passed out of the Senate, and then the House and the Senate would get together and put together a compromise bill, And our hope in that compromise bill, they'll take the House provision, which include the House bill portions that includes our provision, and they have to pass those both. This is called going to conference committee. And so we hope when it goes to conference committee that it'll include our podiatry provision in there. And we are currently working with senators and members of Congress to kind of push that forward. Things you could do, we mentioned earlier, Kimberly mentioned the APMA PAC. We encourage you to contact your senators, ask them to co-sponsor the VA Provider Equity Act, sponsored by John Tester. You can go online. I'll show you the next slide, how to go online to write a letter. We're asking co-sponsors is kind of like credit in Congress. The more co-sponsors you have on the bill, the more popular it is. And so we want to try to make sure we get more co-sponsors. The next bill is the Helping Ensure Life and Limb-Saving Access to Podiatric Physicians Act, or a HELP Act. This is part of our Medicaid access bill, which would, as I mentioned earlier, define DPMs as physicians under Medicaid, and so it would be no longer an optional service. Currently, 7 states don't include services by podiatrists in their state Medicaid program, and it's also only for the adult beneficiary population. And so those patients in those states unfortunately can't get quality foot and ankle care from podiatrists. They can see MDs and DOs, and so what we're trying to tell members of Congress, the foot and ankle care benefit is still in there. What's not in there is that the podiatrists can't provide that care. And we explained to members of Congress that podiatrists really are the premier foot and ankle specialists. And we have studies after studies that show when podiatrists are included in the Medicaid system and other payer systems, payer programs, care goes down and quality goes up. I mean, costs go down, quality goes up. Thank you. And so Jim mentioned the value of relationships. And one of the great things I like, this is a great story I love about the HELP Act. In the Senate, our Republican primary sponsor is a guy named Senator Chuck Grassley from the state of Iowa. Senator Grassley has been in the Senate for years. He's a former chairman of the Finance Committee, which oversees Medicare in the Senate and Medicaid in the Senate. And we have a podiatrist, Dr. Gene Nassif, who's in Iowa, who over time got to build a relationship with the senator and with his staff. And there was a flood out in Iowa, and there was a 5K race, and Gene invited the senator to run with him on this 5K charity race. And they did this 5K together, and the whole time Gene talked about podiatry. And every time Senator Grassley sees Gene, he's like, oh, my podiatrist, how you doing? And Gene comes up to DC a couple times a year to help lobby, and he'll call and harass Senator Grassley's staff a lot. And because of that, Senator Grassley has been our lead sponsor. Again, a very powerful senator, and that happened because a podiatrist in Iowa took the initiative to build that relationship. The same thing in the House. In the House, the current sponsor, the Republican sponsor, is Congresswoman Renee Elmers, who's on the House Energy and Commerce Committee. There, our former president, Phil Ward, lives in her district, built that relationship. Congresswoman Elmers just lost her primary election, so she won't be returning back to Congress next year. We already identified a Republican sponsor to lead our bill, and that is Congressman Bill Johnson of Southeast Ohio. If anyone knows Southeast Ohio, I'm from Ohio, so I know the area a little bit. There's not many podiatrists in Southeast Ohio, a lot in the Cleveland area, maybe Columbus, Cincinnati, but he doesn't really have connection to podiatry. So a constituent, Dr. Bruce Blank, who lives in his district and practices in his district, years ago, when Congressman Johnson became a congressman, invited him to his office, gave him a tour of his office, and since that time has always called him up and asked him to support our bill, and he joined on as a co-sponsor, and then for next year he'll be our lead Republican sponsor. And he's on the Energy and Commerce Committee in the House, which is a priority committee for us because Energy and Commerce oversees healthcare, including Medicare and Medicaid, in the House of Representatives. And so these all happened because these podiatrists kind of took the initiative and built those relationships over time. We have many sponsors and co-sponsors because of relationships that Jim was talking about earlier. And so if you know your member of Congress, know someone on their staff, we encourage you to build that relationship. If you don't know them, do what Dr. Bruce Blank did and what Gene did in Iowa, and take that opportunity to build that relationships if you can. Now, one thing I mentioned about the HELP Act, in 2009, the Medicaid provision was part of the ACA, the Affordable Care Act, also known as Obamacare. It was in the House portion, wasn't included in the Senate portion. But I say that to say that our bill is kind of a smaller provision, so it needs to be attached to a larger provision, a larger bill. And we're hoping next year the Congress will look at Medicaid and CHIP. So we think the opportunity then we could attach our provision to that bill. So we're looking forward to 2017, 2018 to re-energize the HELP Act. Also, the HELP Act does a few more things. It clarifies the documentation issue with the Medicare Therapeutic Shoe Program. We get a lot of calls on that, and so I know it's a problem, so we're hoping to clarify some issues with there and some budgetary savings in there as well. So as I mentioned, we have our e-advocacy program, our state advocacy site. The website's right there. We have already written letters for you. So if you have the time to make that relationship with your member of Congress, but we ask you to spend the 5 minutes, log on, and write to Congress. And do it again and again and again, because your voice really does matter. And when you do write, they do, members of Congress, they collect how many people have written to them, and they report back, hey, we have 25 people in your district who've written about this bill, something we should pay attention to. And then when we go to the Congress, members of Congress, you mentioned that we've had constituents supporting you.
And the beauty of this system is when you log in, it's going to bring up who your congressional representative is and who your senators are. You don't have to do you don't have to look anything up, you don't even have to know who they are. But you're going to be able to, just logging in, it'll be right there for you. And as Chad said, the letters are already done. If you want to customize them, you have that option to add some customization. If you don't, you can just click through it, put your signature on it, and send over to them.
And Priya has a great idea. If you have a computer, we encourage you to log on. I don't mind if you're not paying attention to me. If you're instead doing this, go ahead. You do need your APMA member ID information, so if you don't have that, we can help you out and get that for you later today or probably on Monday. So about 5 minutes or less, you're able to do that. So that's our federal side. Talk about a little bit about our state legislative priorities. We work a lot with our state component societies to pursue a lot of these issues. Scope of practice, as you can imagine, is a big issue. We have 46 states in DC allow podiatrists to use the foot, ankle, and the related structures of the lower leg. There are 4 states that don't. Those are Massachusetts, South Carolina, Alabama, Mississippi, and then as well as Puerto Rico. So we're doing to help our state component societies. We are having a scope of practice advocacy summit in December to bring these states that don't include the foot, ankle, the ankle in their state together to kind of help them to kind of collaborate together and how they can move forward and get their bills passed. We're also, other issues scope of practice is, as you know, in some states you may be able to treat part of the ankle, but not the full leg, or maybe part of the leg, or you can't do fractures. I know in Maryland a couple years ago, and recently in Utah, they can't do ankle fractures or part of ankle fractures, so they recently changed the law to fix that. And so we're working with our state societies to help them update the scope of practice to allow podiatrists to treat the full extent of your education and training. The other part of that is our physician definition. Approximately 35 states define podiatrists as physicians in the Practice Act. So that means you can call yourself a physician or a physician of the foot and ankle or a podiatric physician surgeon. Each state's a little different. On our website, we kind of break it down how it is. But also, in Oregon, they went through their state laws and looked at where, other than the state Scope of Practice Act, but in the state laws where physician is defined, where does it say MDs and DOs and where should it say DPM? So they, about 3-4 years ago, when their law went statute by statute and trying to update their statute, so physician included DPMs as well. So we're also working with our state components to help them with that. We're starting a innovation grant to help them look at their state statutes and to update their scope of practice if they already include the ankle to kind of update it more and clean it up. The other issue we heard about earlier in one of my sessions was supervision of PAs and NPs. That used to be 7 states now. Tennessee recently passed a law, allowed DPMs to supervise physician assistants. As you know, healthcare, the growth of healthcare and large health systems and multi-specialty groups, you are working a lot more with PAs, and so you want to be able to supervise PAs and bill for them. So we're working with our state components to pass laws in those states. I know Utah and Oregon are the next states who are trying to change their law to allow podiatrists to supervise PAs. Finally, as always, work on fee parity to make sure that podiatrists get paid on par with MDs and DOs for the same service. The ACA, again, the Affordable Care Act, had a non-discrimination provision. We don't think it went far enough to protect podiatrists and reimbursement. And so we are working in part with CMS to make sure their interpretation of the law does say that it does protect against reimbursement discrimination. They're also going in states to get, when they're states, to make sure they interpret it appropriately, so you don't discriminate against podiatrists. And then on the regulatory side, quickly, so our Health Policy and Practice Department works with centers and Medicare and Medicaid services to advocate on behalf of podiatrists. Earlier today, Dr. Tillow mentioned the bunionectomies and what RUC recommended. So then RUC makes recommendations to CMS, and CMS will take that and issue a proposed rule called the Medicare Physician Fee Schedule, and they will say what they either agree or disagree what the RUC says. For example, on the bunionectomy codes, they agree with most of what RUC said, but a few things they didn't. And so we take the opportunity to comment to CMS and say, well, this is what RUC came up with, this is why they came up with these reasons. And also the Medicare Physician Fee Schedule has different Medicare policies in there. So we take the opportunity to comment to CMS to make sure that podiatrists can maximize their reimbursement, and so their values are properly valued. The next thing, what Jim talked about was the macro rule. We look at these comment these rules, and we comment. For that one, as Jim mentioned, talked about the small practice, the cost, performance category. So we want to make sure that podiatrists are able to fully participate in these programs, and that they don't discriminate unduly to podiatrists. And then finally, practice to the full extent of education, training, and experience. A lot of times, local coverage determinations may unduly not allow podiatrists to fully practice their level of education and training. And so we work with our carrier advisory committees, which each state component has, to go to these Medicare carriers to advocate for LCD that allows podiatrists to fully be able to practice. The example I give most recently was with pneumatic compression devices and hyperbaric oxygen therapy, where these LCDs said it had to be an MD or DO and didn't include DPM. And so we go in there and work with our state societies to make sure that podiatrists can do those. And then finally, equity in all public payer systems. This talks about, we're not just working with CMS, there's other public payer systems like VA and TRICARE. TRICARE, which is the public payer system for Defense Department. They didn't allow podiatrists to prescribe DME, and so we advocated for that rule change. The next thing we're working on now is they don't allow podiatrists to, or some don't allow podiatrists to prescribe or refer for physical therapy, and so now we're working to change that. And so those are regulatory priorities. Any questions?